Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Zachary Schwartz. In this episode, we discuss a case study that explores how to optimize oral ART for a person with HIV and who has a long history of different ART regimens. I'm joined by Dr. Gregory Huhn from Rush University Medical Center in Chicago. For more information about this program and to follow along with the slides, or to register for one of our live sessions in this series, visit the links in the show notes for this episode. And to get access to all of our new podcast episodes, subscribe to the CCO Infectious Disease Podcast on Apple Podcast, Google Podcast, or on Spotify. Now let's get started with a case study from Dr. Huhn.
This is a 35-year-old woman, so perinatally infected, lipodystrophy, pneumocystis in 1992, so kind of early on, probably in her, again, childhood, adolescent years. Also history of depression. She does take citalopram. So right now she's on dolutegravir and boosted darunavir. This is since 2015, so we're going on 9 years now. CD4 320, she's virologically suppressed. She's subtype B, so probably here in the US. Hepatitis B core antibody negative, surface antibody immune, no hep C, good creatinine, normal lipid parameters. And her BMI is 27, so maybe a little bit inching in between that 25 to 30 zone for being overweight. So how can we optimize this patient's health-related quality of life? So here's what you need to ask each and every visit. How satisfied are you with your current ART regimen? Let's consider if this is still the best regimen for you. And can we consider an injectable ART or just go down to a single tablet regimen? And so again, a little bit more background history from her genotype. So lots of regimens. Not surprising, diagnosed in the early 1990s, so went through nukes, went through PIs. You can see here a host of them in 2009. So again, probably around when she was about 18, 19, she started on a single tablet regimen, efavirenz, FTC, TDF. She achieved virologic control. 2 years later, she was switched to rilpivirine, FTC, TDF. Maybe it was because of pill size, smaller pill size here, but she experienced some periods of intermittent adherence, again, in her early 20s. And so then she was switched to, on her current regimen, dolutegravir boosted darunavir, because of the genotype we see here in 2015. She had a K65R, she had an M184V. So again, intermediate resistance to tenofovir, high-level resistance to bacavir, FTC, 3TC. It was the intermittent adherence to really the rilpivirine, FTC, TDF, probably that resulted in the K65R, M184V. The prior history of efavirenz, again, with a single tablet regimen, that then probably brought along the K103N, as well maybe with the lack of adherence, optimal adherence to rilpivirine. So now she has an intermediate resistance to rilpivirine with the E138K, high-level resistance to those first-generation non-nukes. PI, low-level resistance, atazanavir, no resistance to darunavir, no integrase resistance. She's not been on an integrase-resistant regimen. So do the results of recent clinical trials give us more options than we previously had? We're going to take a look at these trials here, particularly with the integrase inhibitors. So when we look at the phase 3 trials, particularly with the latest iteration and generation of integrase inhibitors, following raltegravir, following abeltegravir, two of them, dolutegravir and bictegravir. So virologic failure in treatment-naive or switch studies with dolutegravir or two nukes is exceedingly rare, very rare. There's been some reports of emergent resistance in treatment-experienced patients, very rare, maybe just a couple cases in integrase-naive patients. And again, dolutegravir has been superior to raltegravir, the first-generation integrase inhibitor, and lopinavir ritonavir in treatment-experienced patients with resistance. Bictegravir, single-tablet regimen with FTC and TAF, non-inferior to dolutegravir with FTC and TAF or FTC TDF in suppressed patients with nuke resistance in clinical trials. Very rare reports of bictegravir resistance in one case report. So again, the bottom line, switching these patients that are virologically suppressed, switching them from one high resistant barrier drug to another. All right, so the NADIA trial, this is an important trial. So this is actually ex-US, primarily sub-Saharan Africa. So these are patients actually that are not virologically suppressed, a viral load over 100. This is 464 patients. They did demonstrate good adherence on TDF, 3TC, or FTC with a non-nuke for at least 6 months. So they're treatment failure with some good adherence, not perfect. They were randomized to either the anchor drug, dolutegravir, or boosted darunavir. And then they were randomized to either 3TC TDF versus 3TC zidovudine, or 3TC TDF on the darunavir arm with, again, similar 3TC zidovudine on the darunavir arm. So they either had dolutegravir with a TDF versus zidovudine backbone versus boosted darunavir with, again, TDF or zidovudine as the dual nuke backbone. So what we see here actually is that they did have measurable baseline resistance. It was not factored into any of this randomization. They were just randomized, but a high level, really, K65R or N, 53%, and M184V. Again, they were failing these regimens. So you expect them to have a very high level of M184V. They did 86%. So intermediate to high level TDF resistance, 61%, and intermediate high level zidovudine, 20%. They followed them for 2 years. On the primary endpoint at week 48 actually showed very high levels of virologic resistance, about 90% or above for all 4 types of subcategories: dolutegravir with 3TC TDF versus 3TC zidovudine, or boosted darunavir, again, with those 2 nuke backbones. But you have some separation when you get into the second year. Week 96, you actually see that TDF 3TC group does better, superior than the zidovudine. There was some resistance in the dolutegravir group, no resistance in the darunavir group. That was statistically significant. The bottom line is that dolutegravir and boosted darunavir, they're both effective, even with partially active nukes, over 50%, and that the emergence of high-level resistance potentially to TDF was not seen in virologic efficacy. Patients still did well, even with a K65R or M184V. Similar results were found in another second-line study with dolutegravir using, let's say, a 3TC or FTC with various versions of tenofovir, TAF, or TDF in the VASCENT trial, also sub-Saharan Africa. We see also in LAMRIS and SOLAR 3D, let's say if you want to switch patients to a 2-drug regimen, dolutegravir 3TC, and if they've had an M184V in their background, this is LAMRIS, observational study. This is actually out of, I believe, Italy. They took a look at 712 patients. They compared patients without M184V with actually a past history of M184V in about less than 10% of their patients. 60 patients had M184V. Those patients usually had a longer history of receiving ART, which was 20 years versus only 7 years for those without M184V. And they had a higher number of previous failures, 3 previous failures versus 0. So more M184V, more failures, longer history of receiving ART. Bottom line, no significant difference in rates of virologic rebound or blips among those with or without an M184V. However, multivariate analysis, if you've had less than 3.5 years since virologic suppression, or of virologic suppression, so shorter term virologic suppression and M184V is more recent, then you have a higher risk, and over 3, almost 4-fold risk for rebounding with viremia. So be careful for switching patients that have a history of M184V to the 2-drug regimen, particularly if it's been recent M184V or recent virologic failure. SOLAR 3D, again, also looked at those with a history of M184V versus not. There was no significant virologic response if they switched on to dolutegravir 3TC. And this was the smaller subset, 50 patients in each group. I think we still need to use caution. If somehow you cannot detect the M184V, if you're feeling that they're a good candidate to go on to DTR, usually they'll do well. But again, there are some caveats here that you may have an increased risk for failure, again, for more recent M184V or more recent virologic failure. So for case 2, is this patient a candidate for long-acting cabotegravir rilpivirine? They have that E138K. They have intermediate rilpivirine resistance. They are not a candidate. So can we optimize the oral ART? BIC-FTAF is an option here. We've seen that data. We've seen from past history of resistance, even with some nuke resistance, no history of integrase resistance, they're likely going to do very well again on the single tablet regimen BIC-FTAF.
Thank you very much to Dr. Huhn, and thank you to our listeners for joining in. As a reminder, to view the full program entitled Contemporary HIV Treatment and Prevention 2024, click on the links in the show notes for this episode. Thank you, and we'll see you soon on the next podcast.